Would you have revision of exams today after the talk?
Not for these two
Not
sessions, but yeah, for the next sessions, yes. I think the way we planned your and Adele's sessions is we have a lot of questions and a lot of enthusiasm. And in particular, I think everybody wants to get a little bit of a flavor of the slight differences in practice. So I thought we'd keep Adele's first and your first sessions as the talk followed by Q&A. Okay. But for the next sessions, what we will be having is we'll be having peer review in the first 30 minutes. And we've kind of worked on trying to have 5 people present a case each so that we're able to give them about 6 minutes and then follow that by the talk afterwards. So with the next sessions, we will definitely be having peer review. Just let a few more people in. How big is your neonatal unit, Almudena?
It's a medium NICU, and compared to the rest of units in Spain, we have 13 beds in NICU and 15 beds in intermediate care unit, and then up to 20 more beds in, you know, like this healthy, almost healthy term babies.
I mean, that's fairly large, I would say. Yep.
Well, we don't have that. We don't have very large intensive care beds.
Sure.
For our, we are the reference hospital from a big area, so we got more people for more infants admitted that really born in our center. Yeah, we are the unit with more extremely preterm infants in our area. So.
And neonatal transport, because you must cover a very large area. So.
Yeah, but it's not covered by pediatricians, not even neonatologists. It's just usual transport is the same doctor that can transport an adult, the children, or infants or newborns is the same. So it's not that high quality, I'm afraid. So you told me you're not using lung ultrasound for BPD? Only for acute diseases, or?
So at the moment, yes, only for acute diseases. For diagnosis, mainly, I would say, for babies who are deteriorating acutely in a variety of different clinical conditions, but actually using serial lung ultrasound in the diagnosis and management of BPD, no, not at the moment. And I think that's why we're very keen to kind of get a flavor of, in particular, you know, the thought of how it might actually be able to kind of empower us to move day by day. And I mean, in particular over here, we have a lot of chronic lung disease. We have a very high population, I'd say about 180 to 200 babies under 32 weeks, which, I mean...
Which is quite big population.
Yeah. And I think a significant amount of that population, because when we theoretically, once we intubated, we can't actually stop life-sustaining intensive care as per religious beliefs and laws over here. So we have a decent survival rate, which means that we have a lot of morbidity. But clearly, I mean, to give you a flavor, an extreme preterm baby, you know, set up over here might end up having about 40 x-rays its entire lifetime, which is massive. The handling, all of the kind of management in the first few hours right up to the time. So I'm just planning an audit project to kind of see how much radiology our extreme preterms actually go through from beginning to end, because it'll be a really good project if, you know, we are able to start implementing lung ultrasound to see how much radiation exposure we can actually save them. I am gonna make us start. So first of all, I would like to thank Dr. Almudena, who is a consultant who works in Cadiz on a neonatal unit in Spain. Dr. Almudena has a huge background in lung ultrasound. And as we all know, and we're currently reading all her papers, in particular papers on lung ultrasound scoring, but have also gone through papers on management with BPD. We wanted to take this opportunity to thank you, Almudena, for giving us, your time today to educate us with regards to this particular topic. But clearly, everybody is looking forward to asking you questions related to all of lung ultrasound at the end of the session. So I will let you make a start. Thank you so much. We're very grateful.
Thank you, Alok. I am the one that's grateful here for you to having this great presentation and for you to be in such an enthusiastic group of people learning this exam that I think has many advantages as you have been learning. So today we are changing the approach. We will be using lung ultrasound not for diagnosing, not for acute diseases or children with acute deterioration. This is not the case. We are seeing that. I have organized this session kind of explaining a bit of theory. Then we will see a few cases, and I hope that with these cases, I think they're illustrative enough that you can try to get the message that you should learn from this talk. So if you have questions or whatever that you need to complete or follow the talk, please interrupt me if you need, okay? So today we were talking about these three main issues. We will see what's the normal or the usual progression of lung ultrasound scores in infants born before 32 weeks gestation. And we would talk about BPD prediction as well, and how can we use lung ultrasound for this issue. And finally, to monitor response to medical treatment that we use for respiratory conditions. Oh, sorry. First of all, you all know now what lung ultrasound score means. It's a semi-quantitative score that was firstly adapted in the neonatal settings by Dr. Nadia's group. And they used it for the first time to try to guess which infant would get more benefits of receiving surfactant administration. And using the similar approach, the same calculation of lung ultrasound score and the same fields, we try to get whether if we can use this to see which infant will develop BPD or not. But the aim of getting these graphs here is to show you that when we compare the evolution of lung ultrasound score in infants born before 32 weeks, we can have this progression as a whole. The infants that don't develop BPD, if we monitor their weekly from birth and until 36 weeks post-menstrual age, you see that those that don't develop BPD will show these high lung ultrasound scores in the first days of life when they are in the RDS surfactant deficiency phase. And after that, you would see after the first week, this decrease in lung ultrasound score that remain low for the rest of the follow-up. However, the infants with posterior development of a BPD disease, you will have this lung ultrasound scores persistently high. And this will be more or less the description of the progression of the score in both groups. But this is not the same in all premature infants. As you can see in this other publication from last summer, in almost 400 infants analyzed weekly from birth, you see that those that finally develop a moderate severe BPD with need of oxygen requirements at 36 weeks post-menstrual age, There's a similar progression in all children independently of the time when they are born. But if you divide them according to those that do have a normal evolution of their lungs, they don't develop a chronic lung disease of prematurity, you see that the progression of lung ultrasound score is not the same in all preterm infants. Those more immature, those born before 38 weeks, do have persistently high persistently high lung ultrasound scores for the first month of life, although they don't develop BPD in the follow-up. You see, this will be the graphical representation in which in the first month, they do have this persistently high lung ultrasound scores that begin to decrease progressively until the end of follow-up. However, those born after 38 weeks do have the same evolution that we've seen before in the previous slide, with high lung ultrasound scores at birth, but they decrease sharply and remain low for the rest of the follow-up. So here, this is an example of a usual lung ultrasound. This is an extremely preterm infant at 26 weeks. And after the first initial phase, when the infant maybe it's still intubated or not, but after the first 2 weeks, more or less, we will see this ultrasound for the rest of the month or even 2 months. And this is the left lung. You see in the cases I will show you, you will always see left lung and right lung, and this will be the anterior field, lateral field, and posterior field, so that you more or less get an image of the whole lung, not just one field of the lung being studied. This is the left lung and this is the right lung. You see that more or less the images are quite similar, irrespectively of the area we are studying. And you see this clear line here with a lot of B lines and a few consolidations. This is kind of normal for this population. The smallest infants will have this lung ultrasound for the first weeks of their lives, and that's normal. And we cannot try to conclude nothing about posterior evolution of these infants if we only take into account this value, the number of the lung ultrasound score, okay? And this also happens the same also if our infants don't need surfactant at birth. I mean, although if they don't have a severe RDS, as you can see here in these two graphs, the most immature infants that don't need surfactant at birth have lower lung ultrasound scores when they are born, but they increase afterwards and remain high until the first month, more or less, which would be this column. Differently than what happens in those that did need surfactant, that have high lung ultrasound scores at birth, but they also have these higher values afterwards. And this is not the case in the more mature infants. The infants born after 28 weeks, after the initial phase of RDS, we've seen that they have a decrease of lung ultrasound scores, but those that don't develop RDS, the usual thing would be that they have lower lung ultrasound scores for the rest of the follow-up. And you can see here the difference between infants born at the lower gestational ages that born more mature, okay? Please excuse me a moment. Sorry for that. Here we can continue now. And this will be the ultrasonographic representation of what Dr. Vankelari and Dr. Alan Job described in 2012, in which the most immature infants develop a kind of an entity called respiratory instability of prematurity after RDS, and between this and the final diagnosis of BPD or not. These infants follow a course in which they need long periods of invasive or mainly non-invasive ventilation. And this is what we are seeing using lung ultrasound and trying to see the lung ultrasound scores in this population. This is an entity produced by multiple reasons. You can see some of them here, mainly due to lung injury by oxygen in the first days of life, overdistension during invasive mechanical ventilation, atelectasis, pneumonia, pulmonary edema or overflow, secondary to a PDA, muscular respiratory insufficiency, whatever. But we have to know that these things happen And we do have to realize that this is normal in this population in trying to know how the lung of these patients are evolving, or to give a prognosis to the families. And after that, when the infant gets the 36 weeks postmenstrual age, this is the only paper published up to date in which the authors compare the evolution of lung ultrasound scores in infants born in infants with a final diagnosis of BPD or not. You see that there's a difference at 36 week postmenstrual age, but this difference decreases progressively after the discharge from NICUs, and values more or less reach the same level when they are 8 months of gestational age. So irrespectively of the severity of the disease that these infants have, when they are more or less at 6, 8, 9 months of corrected age, you can see that the lung ultrasound score decreases and reaches the level of healthy preterm infants. So knowing this, how can we use lung ultrasound to try to predict, to have an early prediction of BPD in this population? Well, this will be an example of an infant with an established BPD. This is a 26-weeker who is now 2 months old. And here you see anterior, superinterior, lower anterior, lateral, and posterior fields. This is a heterogeneous disease in which you see areas with very aeration or another ones that are worse aerated, consolidations mainly in posterior fields with air bronchogram and thick pleural line. So this is what we see when the thing is completely established. But what we know, what we want to do is try to predict it early and try to know if lung ultrasound can help us with this. So when we calculate lung ultrasound score in the first published studies and in the studies about surfactant administration, we use mainly these 3 areas, but trying to get more information about the lung in a chronic lung disease, we have to pay also attention to other areas of the lung which are most affected in this disease. So included posterior fields in the lung ultrasound score created a term called the extended lung ultrasound score. And using this approach, this group of neonatologists from different NICUs in France and Italy analyzed more than 100 infants born before 31 weeks, and they perform serial lung ultrasounds at birth, and then at 7, 14 days, and 28 days of life, and until 36 weeks postmenstrual age. And they compare the diagnostic accuracy of lung ultrasound score and extended lung ultrasound score, but indexed by gestational ages. So we know now that gestational age influenced the value of lung ultrasound score. So they calculated this different approach, and they demonstrated that lung ultrasound score, both the classical and the extended version, do have different values in people, in infants with BPD and non-BPD. And trying to get a diagnostic accuracy of these values at 7 days of life, they had the classical lung ultrasound score and the extended one showed similar areas under the curve with values higher than 0.82. And this Kurov-Bailey's, which is a bit difficult to understand because I showed you that this is lung ultrasound indexed by gestational age. You see that you have this sensitivity, specificity, and positive negative likelihood ratios. They also compare the prediction ability of both scores for BPD, and you can see that there's only a difference after the infants are more are old enough, after 2 months of age. In the first weeks of life, it's not very useful to use the extended version of lung ultrasound score because the lung is more homogeneous. And after that, when the disease of BPD begins to have more prevalent atelectasis and problems in the posterior fields, it's when the extended lung ultrasound score could help us more to see the progression of BPD in this population. This other paper, published a few months after the first one, was performed in different NICUs in Italy, and they included 141 patients from 25 to 30 weeks with similar area under the curve from the study that we've seen before, and they calculated the extended lung ultrasound score at 7 days of life. You see here that with good diagnostic accuracy, however, the probability of developing BPD was different according to gestational ages of the babies at birth. Infants born before 38 weeks do have more or less similar probability of developing BPD, although the lung ultrasound score doubles or triplets the number, or the original number. However, infants born after 28 weeks do have a high increase of the probability of developing BPD with high lung ultrasound scores. And this is because of the issue of the explanation that we've seen before. We know that the infants born at 25, 26 weeks have higher lung ultrasound scores in the first month of life, irrespectively they don't develop BPD or not. So maybe in this population, we have to think of different variables that could help us to know which one would have the worst respiratory prognosis. And uses these papers and some others that include more than 600 infants born before 32 weeks. These papers were meta-analyzed last year, and we got a final pool sensitivity and pool specificity of lung ultrasound score in the first 7 days of life of these values, which could be, which are moderate predictors, if we only take into account lung ultrasound in this population. So we have to think that maybe combining different variables could give us more information than not just the number of lung ultrasound score in extremely preterm infant. And this is something that we did, and trying to combine clinical objective variables, like for example, gestational age and sex. If we only take into account these two variables and the number of lung ultrasound score at day 7, we can increase the diagnostic accuracy of lung ultrasound score for BPD prediction in this population. If we take into account more complicated models with the needle-invasive mechanical ventilation at day 7, or PDA, or latent sepsis, which could change from one unit to another, or even the diagnosis of these diseases could be different and not clearly established. Maybe we have similar diagnostic accuracy with subjective and small number of variables in the models included. And this is something that we also replicated when we perform lung ultrasound as early as 3 days of life, in which gestational age we have similar diagnostic accuracy that can be increased if we take into account the value of lung ultrasound score at day 3. So this was replicated also in this paper by Dr. Mohammed that was speaking yesterday, in which they also performed similar approach, combining lung ultrasound scores in different moments and gestational age, sex on the needle-invasive mechanical ventilation. You see the area under the curve of these models that maybe in the future we would be using to detect which infant has the highest chances of developing BPD. So now, how can we do it? This is, as we've seen, this is something that is growing now. The reference are appearing very recently. The first ones are from 2019. So I think we are now at the moment to say that we can detect early BPD in the most mature infants. I mean, those born after 28 weeks, as you've seen now. But we have to have some other tips, in the most immature infants that we will be seeing after these first cases. Now I want to show you a few more, just a few cases to see how we do it. and see how easy we can see the difference between some infants and others. I've organized this talk trying to be practical for you to see images and for you to see how easy it is to see how the lung is evolving from one infant to another. First two cases are twins. They were born by an ectopic delivery at 32 weeks gestational ages. They didn't require resuscitation at birth. They were born with these birth weights, and both developed deep respiratory distress in the first minutes of life. Both were placed on nasal CPAP, but the first one has higher FiO2, 32%, and the other is below 30. Here you can see lung ultrasounds of the first twin at the first hour of life. This is this part of here is the right lung, and this is the left lung. Just I'm showing you the anterior and lateral field. You see the aeration, which is not quite bad. The infant is with FiO2 32%, and this is the second infant, the second twin, which has a very aeration and requires low FiO2. So according to the talk that you have the other day, just the first one received surfactant by Lisa, which developed a positive response. And we were able to decrease FiO2, and the other remained on nasal CPAP, but he required nasal IBPE due to apneas at third day of life. So the first, the first ultrasounds that we are watching in these infants were different. The evolution was different, but after that, if we perform lung ultrasound at 3 days of life, you can see that both have similar exams. Both have this thin pleural line, more or less, but both have this interstitial pattern with an increase of B lines, which we shouldn't see, at least in the second twin, which didn't show this image at all in the first hours of life. And you see the progression, the progression was clearly seen here. At 7 days of life, both have similar ultrasounds also, and you see this severe B pattern or severe alveolar interstitial syndrome that you can see here, which we've seen that it's not normal after 1 week of age in infants born after 38 weeks of life. So when you see this progression, this is not normal. These infants do have a high risk of developing BPD. Okay. The thing is that you should have the image. This is not an static image. If you see this for the first time, maybe you're not able to have an idea of what's going on with the lung of these infants. You have to take into account the image and the clinical picture that these infants had when they were born, then at 3-4 days of life, and then the progression after 1 week of life. So after that, we say that the first infant required nasal CPAP until 25 days of life, and afterward, a few days more low flow nasal cannula, and the second one remained on nasal CPAP until 22 days of life with no respiratory support afterwards. So they needed respiratory support at 36 weeks, but they didn't have a severe BPD or whatever. We can only say that these infants still will probably will need oxygen at 36 weeks of menstrual age. Okay. Next case, it's an infant born at 31 weeks with this birth weight. He was born due to an urgent cesarean section because of maternal preeclampsia. And he received a complete course of parenteral corticosteroids, didn't require resuscitation at birth. So he received nasal CPAP in the delivery room, didn't receive surfactant at all. And this is lung ultrasound at third day of life. You see the different progression of the different exams compared with the other twins, in which we have this thin pleural line, lung sliding, no B lines at all, just 1 or 2 or 3 in the posterior fields. So this infant didn't have a bad prognosis at all. The infant was still on nasal CPAP. Also, the others more or less the same. And you can see lung ultrasound at 7 days of life. nasal CPAP withdrawal was a failure at 3rd day of life because of apnea of prematurity, but we were able to remove nasal CPAP at 7 days of life, and he didn't require respiratory support afterwards. So this is more or less the different progression that we can see in this population. And this this 3rd case will be a preterm infant born at 28 weeks. She was born at, with 780 grams. She was a triplet, and she also received a complete course of prenatal corticosteroids. She received a cesarean section because of type 4 intrauterine growth restriction, and she received PPI at birth, and afterwards she had a good response and was transferred to NICU on nasal CPAP. This is lung ultrasound performed at 3 days of life. You see there's a small differences with those that we've seen before. This is a smallest infant, but we also see that the pleural line is not as thin and as clear that we were seeing in the previous infants. You see that this pleural line is fragmented. You see there's very small consolidations, very small atelectasis here at the level of the pleural line. And this is not of good prognosis, as we will be reviewing after that. Now the infant was on nasal CPAP. She's quite stable, and this is the lung ultrasound performed at 7 days of life. And you all know now that when we see this, the pleural line is still fragmented. We have this in alveolar interstitial syndrome with lots of B-lights in all field study. This is not of good prognosis. The infant was still on non-invasive ventilation at the 28 days of life, then required nasal CPAP, then again non-invasive ventilation until 15 days of life, and finally she was discharged home on oxygen. So you see that this is more or less what we are doing, and this is more or less how you can approach lung ultrasound in this population. But we were saying that the value of lung ultrasound score for trying to prevent or trying to diagnose early BPD is not the same in all preterm infants. And the ones that we are more worried about are the extremely preterm infants born before 38 weeks. And in this population, as you can see here in this graph, the first weeks of life are quite similar in terms of lung ultrasound score. You see that there's a decrease after the first month in both groups, but the decrease is lower in those that finally need 36 weeks, need oxygen at 36 weeks post-menstrual age. So maybe we have to take into account different signs, different ultrasonographic signs in this population to know which one would have the high risk of developing BPD. And as you can see here, in infants born before 38 weeks, comparing in the first weeks of life, comparing those with finally diagnosis of moderate severe BPD, we know that the number of consolidations, lung consolidations in infants with moderate severe BPD is higher. They also have a higher number of consolidations before the first week. We know the consolidations are frequent in RDS. So we have to divide before the first week when the infants are still in the RDS phase and after the first week. So in the first week, there's difference also, but the difference between the two groups is lower. And when we compare after the first week and in the first month of life, you see the difference in the number of consolidations in those that finally develop BPD and those that don't. So when we have to pay attention to this, to the existence of consolidations, and maybe these other signs, like this one from a Chinese group that described the debris sign in lung ultrasound. This study was performed a bit later at 38 days of life, but you see that finding this kind of small atelectasis, very reduced millimetric consolidations do increase very much the risk of developing BPD. So we have to pay attention very much to the level of the pleural line and the existence of consolidations in this population, not just the value of lung ultrasound score. And this other publication, which was performed in the first week of life, not only in extremely preterm infants, but all infants born before 32 weeks, we can see that lung ultrasound score, high lung ultrasound score increases the risk of developing BPD, but you see the odds ratio for developing BPD with consolidations at 7 days of life is almost 10 times higher than the number of lung ultrasound score itself. So the existence of consolidations, of fragmented pleural line, small atelectasis at the level of the pleural line, I think are the tips that you have to look at when you are analyzing an extremely preterm infant in the first weeks of life. And here I wanted to show you some examples also of these issues. This is a preterm infant born at 36 weeks with this birth weight, and she was born by a thoracic spontaneous delivery with a complete course of corticosteroids. She had low respiratory drive at birth, so she was intubated. She received 1 dose of surfactant and she was extubated at 12 hours of life. And here you see this infant is extubated now on non-invasive ventilation, but you see the lung ultrasound of the anterior, lateral, and posterior fields in the left lung. You see how pleural line is not complete at all, it's fragmented. You see small consolidations which don't really have much significance in terms of oxygen requirements. Maybe the infant is with FiO2 21, 25%. But when you see this in the ultrasound, you have to really pay attention to these infants in terms of respiratory evolution. This is the right lung, also anterior, lateral, and posterior fields. And you see this small consolidations, this fragmented pleural line here, all together with a high lung ultrasound score, but it's not the same nice picture that we were seeing in infants, in extremely preterm infants with low risk of BPD. And this is the lung ultrasound performed this is the left lung at 14 days of life. You see how lung ultrasound scores are high. It will be a 2 probably in all fields, maybe 1 here. But if you take into account this fragmented pleural line, this small atelectasis, very millimetric atelectasis, which are not seen in an X-ray, of course, you have to pay attention to these infants. Okay, this is the red lung also. You see the lung is more or less aerated the same. You see here a big consolidation in posterior field, but this patient needed non-invasive ventilation until postmenstrual age of 36 weeks. She still needed a low flow nasal cannula for 10 days more. And finally, she was discharged home without oxygen. But we were able to see this in the first week of life. So maybe in the future, if we could have a treatment or something that reduces the BPD, maybe we can incite it in infants with high risk, really high risk of developing BPD. Next case, this is a preterm infant born at 26 weeks. All these 4 cases are infants born before 38 weeks. This is a twin pregnancy. The infant was born 3 days after his sister. There was this was a deliver. They were delivered in different days because the sister were born first, and gynecologists decided to do a later deliver of the second twin, and both received complete prenatal course of corticosteroids, and he was born by a cesarean section because of the breech presentation. He didn't require resuscitation at birth, and he was transferred to NICU and nasal CPAP. And this is a lung ultrasound score performed at 3 days of life, in which you see how, oh yes, lung ultrasound scores are high because it would be 1 or maybe 2 in most fields, but you see how the pleural line is thin, very nice, clearly delineated. You don't see fragmented pleural line at all. You don't see any consolidations. And at 7 days of life, you see how lung ultrasound score maybe is higher than the 3 days of life, but pleural line is nice, clearly drawn. You don't see fragmented areas. You don't see consolidations at all. So this infant is not a high-risk BPD patient. He was stable nasal CPAP with low FiO2 for 20 days, and we were able to remove nasal CPAP after that. He didn't need an increase of respiratory support during his follow-up, and he didn't develop any morbidities at all, although he was born at 26 weeks, I remember you. Next case will be an infant born at 25 weeks by a cesarean section due to breech presentation. Also received a complete course of postnatal corticosteroids, and we were unable to extubate her at 7 days of life. And this is the lung ultrasound that we got at 7 days of life. This is the left lung ultrasound, anterior, lateral, posterior fields, in which you see the pleural line is quite nice. It's clear, but lung ultrasound score is high also. But you see here a big consolidation, a big consolidated area in posterior field in one lung, and the right lung, you see these areas with fragmented pleural line here, and also huge consolidation posterior field of the other lung. So when you see this, you also have to really worry about the respiratory status and the follow-up of this infant. We were not able to extubate her until 1 month of life. And after that, she was in non-invasive ventilation at the 39 weeks postmenstrual age. And finally, we were able to discharge her home without oxygen. But you see that the evolution is completely different between apparently similar infants for similar conditions. And this one is the last case, which is the more severe case, I think, that we've had, but it's quite illustrative, and I think it's very easy for you to see the progression of lung ultrasound scores and lung ultrasound SAMs to give you an idea of what you can do with your exams. This is a 25-weeker. She was born due to a maternal choramnionitis with the mother that was colonized by Uroplasma parvum, which you all know increases the risk of BPD. She was born by a vaginal delivery, but she required intubation at birth, and she received 1 dose of surfactant. This is lung ultrasound performed 4 hours after surfactant. You can see how nice lungs are. They are quite well aerated with thin pleural lines in all fields, with almost no B lines, A lines all over the areas. A bit less aeration in posterior fields. The infant remained clinically quite stable for the first weeks of life. She was with low FiO2, although we were unable to extubate her. She also was positive for Uroplasma parvum, and she received azithromycin for 3 days. But although she was quite stable, you will see now the progression of her scans. This is at 3 days of life. You know how the pleural line is beginning to get thicker here with small areas of fragmented pleural line. We also see increase of lung ultrasound score, which really doesn't worry us much. But see what happened at 1 week of life. We have this thick pleural line with consolidations, small consolidations, but this is not good. This is not a quite good evolution. This has to worry us very much. And if we add this to the fact of being a Uroplasma parvum positive mother with a suspicion of choramnionitis, we have to think that this infant really has an increased risk of developing BPD. However, we also were thinking about beginning postnatal corticosteroids in this moment because of the highest risk of this infant for developing BPD. And after that, The infant had an increase in respiratory support after the first 2 weeks of life. She developed a very severe disease with still intubated at 36 weeks post-menstrual age with FiO2 100%, inhaled nitric oxide, corticosteroids, and diuretics. So with all this, more or less, you can have an idea of what you can use lung ultrasound for, both in extremely preterm infants and very low birth weight infants. And you more or less know the difference and what are the signs that you have to pay attention to try to guess the evolution of this of the lungs of these infants. And just a few words to talk about how can we monitor the response to medical treatments in this population. Now that we have an infant with an established BPD or evolving BPD infant in which you decide to begin a specific treatment for the lung, like for example, corticosteroids or diuretics, you can also use lung ultrasound to monitor the response. This is a few cases that we presented a few years ago in a meeting in which you can see the evolution of lung ultrasound score after the beginning of treatment with postnatal corticosteroids. And you see how all of them had a decrease of lung ultrasound scores and also a decrease in respiratory needs. This is a clinical case of one of the infants that we've seen before. She was a 25-weeker, intubated at birth, and still intubated at 1 month of age, with non-invasive ventilation until 36 weeks menstrual age, which didn't have really changes in her lung ultrasound since the first week until the first month of life, or even afterwards. This is more or less the basal lung ultrasound of this infant. This is the usual thing that we see. This is the pleural line with lung sliding, lots of B lines in every area that we evaluate, and a severe interstitial pardon that we were unable to decrease respiratory support or remove nasal CPAP after quite a long time. So we decided to begin postnatal corticosteroids, although very late treatment, but this is after after a few weeks of life. After many weeks, we are always watching the same lung ultrasound images, no changes at all. We began corticosteroids, and after 2 days after that, you can see how the exams have changed. Mostly in lateral and posterior fields, you see how thin the pleural line is, no consolidations at all. We can see almost reduced number, almost disappearance of B lines. And this is one lung and this is the other. You see how after many weeks waiting and seeing the same pattern in lung ultrasound, you can see when there's a change when you give a treatment, and maybe the infant will have more chances now to be able to have remove of non-invasive ventilation, and that was what happened. Lung ultrasound score remained low, so we were able to remove non-invasive ventilation after 1 week of beginning the treatment, and she was discharged home without oxygen finally. Diuretics, for example, it's something that some centers also use in BPD patients. We don't use it routinely, but sometimes we use it. And this is a small study that we performed with only 18 infants that receive diuretics. We divided them according to be a clinical responder or not in terms of reducing respiratory support after the initiation of diuretics. And you can see how lung ultrasound scores decrease just in the very first day after the beginning of treatment, just in the group of infants that were clinical responders. However, those non-responders did show similar values of lung ultrasound scores after the treatment. So we can also use this to know whether we will find a respiratory response, positive response in this population. This is another paper published by published by a group from the US, in which they didn't use lung ultrasound score properly. They use a score that they call pulmonary edema severity score, in which they counted B lines, which is not really the optimal approach, because you know the difference or the problematic that could be differentiate the exact number of B lines. But you see how they also got a decrease of this score in the infants that received diuretics compared with those that didn't in the follow-up. And they also saw a decrease of respiratory support in the infants that received diuretics. So after all this, I hope you didn't have quite a long talk. You've seen how lung ultrasound score do progress differently in very low and extremely very low birth weight infants. That using BPD prediction, we can use it as early as 7 days of life. If we take into account lung ultrasound score only for those born after 38 weeks would be good. You should see almost a lung ultrasound score near 0 at the first week of life. However, in infants born before 38 weeks, we have to take into account both lung ultrasound score and the thickness of pleural line and the fragmented pleural line or the existence of consolidations. And you now know that you can also use lung ultrasound to know the response to medical treatments that we use in extremely preterm infants. I hope this is good for you. And now I'm open to all your questions.
I'm gonna take the opportunity. Yeah, sorry, I'll let you give the acknowledgements. Go for it. Yeah, Almudena.
Yeah, I will only want to acknowledge my colleagues from Spain, from different units that have helped us with all these studies, and also all the different hospitals all around the world. You have my email also for any questions that you could have after these sessions. Thank you so much.
So, Almudena, I have a few questions. So my first question is just in terms of evaluation for, say, bronchopulmonary dysplasia, because it's an evolving kind of a clinical picture. When you do, I mean, your guideline in your unit at this particular point for following such babies up, is there a difference by gestation? Do you follow the more preterm babies more frequently, or do you have a kind of a standard protocol for all babies, maybe say 22 to 32 weeks?
Yeah, we always try to get the first lung ultrasound before surfactant administration, and then we perform another exam at 3 or 4 days of life. And after that, we perform it at 7 days of life and 14, or more or less every 1 week.
And just out of curiosity, when we're kind of looking at the lung ultrasound scores, there's a lot of literature talking about the use of the extended lung ultrasound score, in particular the posterior regions where consolidations are more common. And I just wondered, I mean, what are your thoughts? Because at the moment we're using the BRAT score, very much not doing the posterior regions, but clearly, what are your thoughts? What would you be using?
Well, in fact, when you're analyzing the lung of an infant's lung, we have to analyze all areas because you can find a consolidation and you can try to recruit it if you think the infant would have deterioration in oxygenation index because of that. Although the risk of developing BPD is not increased as much when you find consolidations only in posterior fields. I mean, when it's different if you're aiming to know the situation, the respiratory situation of your baby, or if you're aiming to try to predict BPD. There's also some studies that I haven't shown here in which consolidation only in posterior fields in extremely preterm infants doesn't increase that much the risk of developing BPD. Only the existence of consolidations in non-dependent areas like anterior and lateral fields do increase the risk of BPD. But if you find one, of course, you can try to recruit it, or you can use you can change the patient position to try to reduce the oxygen requirement or improve ventilation of that infant. Or maybe you want to know whether the infant is developing a nosocomial pneumonia or something. But the aims are different. We're always trying to explore all fields in our infants, whether if they are clinical stable enough. But the images or the findings that you get have to be interpreted differently depending on what you are aiming for. Does that answer your question?
Absolutely, that's really helpful. Naz?
Thank you so much. That was really informative. Thank you for coming for this. Can I be a devil's advocate and question you as to how would the doing lung ultrasound for prediction for BPD actually help me clinically? Because it seems to correlate with clinical, the scores for lung ultrasound. So why don't I just use clinical? The reason I'm asking this is putting lung ultrasound practically in the neonatal unit. I am going to meet a lot of resistance. So if I have to sell it, I need to know what I need to sell. Also, does it help to, you said it helps to start, you can use it to predict or show effect of the treatment if you're using diuretics or steroids, but can I use it to actually start the treatment as well? And along with predicting BPD at 36 weeks, can I use it to predict going home in oxygen, say at 40 or 44 weeks?
Yeah, you can use that. I mean, high lung ultrasound scores are related to prolonged need of oxygen or need of oxygen when they are discharged home, and also the need of postnatal corticosteroids. However, as we don't have universal criteria to decide which infant do need postnatal corticosteroids, I couldn't give you a threshold, an optimal threshold in which infant will receive postnatal corticosteroids. I don't know if you understand me. There are different publications in which we know that high lung ultrasound score are related to the need of postnatal corticosteroids or being discharged on oxygen, but as different centers do begin treatment at different clinical situations, you cannot have practical issues in which infant would need this treatment or which infant would need prolonged use of postnatal corticosteroids, for example. In the next talk that we will be having in 2 weeks, we would show you how you can use lung ultrasound score to decide when to remove non-invasive ventilation and when to decide when is the optimal moment to extubate an infant, for example, an extremely preterm infant. And maybe in the future, if we would have a treatment, an effective treatment for BPD, we could use it for those infants with high risk of BPD, and as you've seen some examples here. Now the only treatment that we have is postnatal corticosteroids. So I would use postnatal corticosteroids in those infants which have high risk of BPD according to lung ultrasound. But this is not, this has not been studied, a formal study nowadays. So we cannot give you a recommendation for using this in your unit.
Thank you.
Dr. Zaradeen.
Oh, thank you very much. Thank you so much for the very, very nice presentation. I have a quick question about the score, the use of the lung ultrasound score. As I understood, the score is not as sensitive in predicting chronic lung disease in extremely preterm babies, meaning under 28 weeks. So based on this, you said that it's probably becoming more sensitive when you add the pleural line and the consolidation factor. Is it not time to maybe redesign the score in the first place to make it more predictable of chronic lung disease in this group of babies? Thank you.
Yeah, we could do that. The thing is that some groups have performed this and they have created different scores, but these scores are not validated, and we don't know now the inter-agreement, the reproducibility of changing scores. Maybe the existence of number 3 could be different to what we call number 4, and this is something that has been very criticized in the studies that some groups have tried to do so. So I would, in what we are doing now, we are included 200 more infants in a big multi-center study, in which we would combine the use of lung ultrasound to pleural abnormalities and the existence of consolidations, and trying to sum the values of all signs together to try to get more information and try to have a better diagnostic accuracy of early lung ultrasound in BPD prediction. So try to assay specific treatments for those infants with high risk of BPD.
Thank you.
Almudena, I just had another question. So we obviously talk about the heart-lung interaction and evolution of BPD. And I'm just curious, I mean, in evaluation of the PDA and whether you look at PDAs in your unit and whether we've looked at correlation of lung ultrasound scores in babies who have large PDAs versus those that don't, and how that might have influenced BPD. I'm just curious.
Yeah. There's a few papers in which the authors have analyzed. I could have talked about this maybe in this lecture, but I thought that you weren't interested as much. But there's just 4 papers published nowadays in which the authors compare lung ultrasound changes in infants with PDA or not. And you see that in the first week of life, those infants with a persistent ductus arteriosus showed higher lung ultrasounds, which is the logical thing. You have pulmonary edema or overflow due to the PDA, you will have higher lung ultrasounds. But after that, after the first week, we've seen that all extremely preterm infants have an increase of lung ultrasound scores. So the ultrasonographic description of an evolving BPD or an infant with PDA is similar. So the images that you see are quite similar, and after the first week, you're not able to see any difference at all. The only thing that you can look at is the existence of consolidations and pleural line abnormalities. So after that, after the first week, when you see this, that patient is evolving to a BPD clearly established, an inflammatory disease with consolidations, atelectasis, and so on. Maybe that infant also has a PDA, but the thing that if the infant is requiring high respiratory settings, that's maybe related to an evolving BPD instead of persistent ductus arteriosus. We have sent an abstract to PA's meeting this year in Washington, in which we compare, we perform heart and lung ultrasound in extremely preterm infants, and those with a PDA, a positive PDA, we couldn't find difference in numbers of lung ultrasound score when the infants were below 38 weeks of gestation at birth. So this is more or less confirming this hypothesis in which you cannot differentiate only with lung ultrasound scores infants with a PDA or a respiratory insufficiency of prematurity because of being born very immature.
That's really helpful. Dr. Hassoun.
Yes, thank you very much for this fruitful presentation. For the lung ultrasound, as you have been shown that we can use it for monitoring of treatment, like for example diuretics or postnatal steroid. But can we use it, for example, for other treatment like inhaled steroid or fluid restriction?
Yes, you can use it also. We haven't tried that. I only wanted to show you those that we could have some evidence that it is improved, but anything that you do to improve the lung aeration, you can monitor lung ultrasound. You can use lung ultrasound to monitor this. For example, if you change the infant's position, if you increase respiratory support, if you use or decrease extravascular lung water or whatever, you can see an improvement in lung ultrasound scores, and that correlates with the respiratory stages of your patient.
Thank you.
You're welcome.
Any other questions, folks? Anybody else want to ask a question before we say thank you? I think I'd just like to take this opportunity again to thank you, Almudena, for an absolutely fantastic talk. Clearly now a little bit more for us to practice in terms of scans for babies maybe who are preterm and have evolving lung disease, for us to kind of have a look at some of the signs that Almudena has looked at. But I would just like to take this opportunity to thank you for speaking to us today, sharing your valuable time, and we really look forward to the next talk. Thank you so much.
Yeah, I'm very grateful also for your questions, and you're really quite a good team.
Thank you, everyone. God bless, and we will meet again on Friday.
Bye.
Bye.